And good morning and welcome to Health Talk here on AM 1270 and 96.5 FM KXBX. I'm Paul Thomas. With me today is Bill Kearney of Northlake Medical Pharmacy. And Bill, sounds like you had a rough Christmas.
Yeah, I was. I'm going to try this.
Trying to make it through.
I've had this bronchitis and this virus that's going around and filled up my head where I couldn't breathe, and I was coughing, and my employees told me not to come in, because I didn't want to spread it. So I had a fairly decent day yesterday, and then at nighttime I fill up again. So, but we're here. We made it through Christmas, and hope it was a good day for you. It was a good day for us.
You know, I woke up not feeling well on Christmas either, and haven't felt well really until today. It wasn't any kind of a lung thing or a sickness. I just felt like, you know how your body feels when you have the flu.
Sure. Just
really cold and beat down kind of a thing, and stiff. Woke up with stiff neck and my wife, she kind of has felt the same way, but she's been having the bronchial thing for a little while now. So
yeah, that doesn't go away. Yeah. It sticks around for quite a while.
It's been a couple of weeks, and then what was really kind of scary is I guess it was last Wednesday night. My daughter and grandson came in to visit, and they were going to stay for a couple days. And that night, Celia was went to put the baby to bed, and he was coughing so bad and pointing at his chest saying owie, owie, and wheezing, and so Celia took him into the doctor, and he has double pneumonia. He has pneumonia in both lungs.
Wow.
And he's not even 2 years old yet. And so there's a lot of really bad stuff going around out there.
Yeah, that's really serious for a child that age, because they don't have the lung capacity we have to start with, and it becomes very difficult for them to. Lots of kids that don't have a medical place to go end up dying through double pneumonia like that.
Yeah.
So it's a very serious thing. Well, this is I don't get put down very often. I'm able to function. And I made it till 7:30 every night, and by then, the rest of the crew was just cranking up, getting ready to go, and then we had
have fun, huh?
Had everybody around the bar and everybody out looking at all the Christmas decorations, and it was a good weekend. And but I hate it when I miss work like this, and a lot of things going on with healthcare that we need to talk about at the end of the year, and with all of the things that may or may not happen to Obamacare. And as we continue to look at what we can do to make things better, there have been what we call accountable care organizations, which are organizations that we've talked about this with medications before. They charge some of these medications are so expensive that they are going up because they cure a disease. Well, the accountable care organizations is an idea to make physicians more mindful of costs. And is that really necessary? But while keeping people healthier and away from pricey hospital visits, in recent years, there's been several hundred accountable care experiments that have sprung up nationwide. And if you start thinking about this, it may be a good thing for the patients. And this is kind of a wellness issue. If we treat people to get them better, they will use the facilities less. So Medicare, which is the federal health insurance program, has embraced this idea. And the Secretary of Health and Human Services pledged that by 2018, half of the traditional Medicare payments would be based on models of accountable care organizations. But you start thinking about the people that treat the sick people, which are physicians. It's if they come into the doctor's office less, and if they go to hospitals less, then the physicians are making less money. And what's happened in a lot of these accountable care organizations, the physicians have deserted those organizations because they can go to a hospital that doesn't have ACOs and make more money. And the hospitals get, if they have a readmission within 30 days of what the person was in there for the first time, they get dinged by Medicare too. So it can be really tough to overhaul the way medical care is delivered, even when the change is a priority for doctors and the government. And that's kind of what the government has done. And it takes me back to about 10 or 15 years ago when I was on the board of directors at Sutter for so many years. We had a CEO that believed in wellness. She came from the Bay Area. Her name was Kelly Mather. I thought she was a very good CEO for what we were going through with the unions going on strike and a lot of unnecessary situations going on within the hospital. And she tried to sell wellness, which is a concept that makes a lot of sense. If you can keep people well, then they need health care less frequently. The problem of that is, on a hospital, you operate with a lot of revenue that is donated by wealthy people or people that have money to donate to the cause. Our experience was that we went to people that were benefactors that would like to be in a position to donate money, and they wanted to donate it for something they could physically see, like a piece of equipment or like a wing of a hospital or something like that. Well, when hospitals were struggling and they needed physicians and excuse me, they needed patients, it was tough to sell the wellness concept. And if you look at organizations now that are trying to go towards wellness, as well as pharmacies are graded on a wellness type of intervention where we have to intervene with medical prescriptions to make sure that the patients are taking them correctly and they're being prescribed correctly. And we are dinged by Medicare and pharmacy benefit manager companies if we don't get involved with the health care. In order to get us involved and physicians involved, they have to pay a premium for us to review what we call medical therapy management. And in order to do that, and we make the giving of the medication more efficient, but an accountable care organization over that period of time is going to see the patient less. And if they see the patient less, the physicians are going to make less. And so they go to some place like Kaiser or another organization that doesn't, and Kaiser does a pretty good job at emphasizing wellness, but of course the hours are limited compared to what they would be at a private or a community type hospital. So it also suggests that while independent practices like these accountable care organizations may have more flexibility than big hospitals when they want to test these models, they may not have the capital. And we are constantly operating hospitals on minus revenue. And people that are in an organization where a hospital isn't a standalone hospital, like Sutter, who has several different, has hospitals that are generating revenue that are taking on hospitals that are just merely holding their own, just so we have a place to go. So it's like trying to change a tire on a car when it's going 60 miles an hour. When the efficiency of the organization is at its highest, it's almost impossible to cut down what kind of money you're spending if you're maximizing the amount that you get in revenue in return. So accountable care organizations are supposed to be a wave of the future. You're supposed to see a lot more of those. Prodded by Medicare, the number of accountable care organizations has soared from to 630 in 2016 from roughly 75 in 2012. So the Trump administration may slow the government's push to this direction. Excuse me. And insurers and others have said the shift to new models was unlikely to change. There isn't a plan B. This has to work. So under one version of an accountable care program set up by Medicare, groups are eligible for a portion of what they save in medical costs if they meet certain quality goals. So that means if they're able to save money, the people implementing the care are able to share in a bonus type thing. We've had those organizations try. Western Physicians was one of the ones that we tried several years ago in Lake County. It failed. We tried the Sutter Trust Foundation in Lake County, and that failed. So it's unfortunate that we're not having the kind of health care that we had before. It's unlikely that this is going to change, that they're going to keep trying to work at these organizations. And so what we see happening are fewer and fewer physicians in rural areas like this, and more physicians' assistants and people that are working as second-line physicians in order to get the health coverage. And you're seeing massive turnovers in where the physicians are. That's why when you go to a hospital and you want to talk to your physician that you once had, they're gone. And if they're in private practice, they leave, and then it's hard to get somebody to replace them. It's still very pricey to go to medical school. It's a huge commitment, just as it is in pharmacy. And where we have to go 5 and 6 years, they go 8 and 10 years. When we come out of pharmacy school, we have at least $250,000 in loans to pay off. Physicians have frequently twice that much. So how do we get around? How do we make this work? You're going to see healthcare change, and you're going to see legal battles over this of people not being taken care of, and you're going to wonder why this has happened, and it's because the medical system is broke in this country. We pay more for medical care than any other place in the world, and we are one of the least efficient carriers or providers of these services of any country in the world, and it has to change. So our number is 263-5252. If you have any questions about your health, any questions about what we're talking about, please give us a call. We talk all the time about price spikes on prescription drugs. It's getting to be horrendous. Congressional reports can get pretty boring, but Wednesday's, which was last Wednesday's adept account of price gouging among prescription drug makers, has been giving people that were listening to this a huge insight on what some of these drugs are and what they're doing. They're still working on this in Congress, and it's unclear where the Senate may set its sights, but fresh Medicare data points to big companies like Mallinckrodt, which makes a product called HP Acthar Gel. It's a vintage off-patent drug whose cost has rocketed from $40 a vial, $40 a vial now, to $38,000 a vial today. You may not have heard of it, but if you pay taxes, you're an interested party. It's marketed for several different afflictions, including acute series of multiple sclerosis and rheumatic disorders. According to the Medicare drug spending dashboard for 2015, it was the single most expensive drug per patient that the government paid for during the course of last year. Of the 3,100 beneficiaries using Acthar, Medicare spent an average of $162,371 per patient. I'm in a co-op, as most of you know, and I travel all over the United States with 1,400 stores, and I'm head of the western part of the United States. We have one of our stores that is in the millions in their volume every month from selling Acthar gel. Total Medicare spending on Acthar was $504 million last year, a 29% increase from the year before. The 2015 spending was up from $49.5 million in 2011. So that's topping the Medicare dashboard, and that's hard to do today because of the Harvoni and the hepatitis C drugs. They were worried that Medicare and that Congress might soon examine the operation. After all, the pricing pattern is very similar to those of the companies singled out by the Senator Aging Committee. But Mallinckrodt believes that has none of the characteristics that trouble the Aging Committee, and it's not the drug with no immediate competition, and Mallinckrodt has controlled the access to it in a closed distribution system. So we couldn't even dispense the drug, nor would I want to, with the amount of rebate that we would get getting back. As for the cost, the company did not dictate the price when it acquired it in 2014. And under Mallinckrodt, who's the company, price increases have averaged in the low single digits, is what the company has told us. It's true that the biggest price increase came under the drug's previous owner, which was Questcor. So a look at their financials tells the story. It accounted for 34% of the company's $3.381 billion in net sales in the most recent fiscal year. That makes that drug a $1.15 billion drug for the company. We're paying the freight as taxpayers to a greater degree than private insurers. While Aetna, Cigna, and United Healthcare have restricted reimbursement, Medicare continues to pay. If Medicare pays, you pay. That's because the Center for Medicare and Medicaid Services, as a unit of Health and Human Services, provides reimbursement for any medication determined to be a covered Medicare Part D drug, and Acthar meets that criteria. I don't know what to tell you when it comes to where healthcare is going, and I hate to be a downer so many times on what's going on, but sometimes when you see us struggling out there and see how difficult it is for us to exist, and there was a July of this year policy from United Healthcare, the nation's largest payer, that Acthar is more expensive than alternatives that are likely to produce equivalent results. Therefore, the drug is unproven and not medically necessary for all but 3 of the indications on the label. TRICARE, which is the insurer for members of the United States military, also limits reimbursement solely to infantile spasm. So the history shows just how profitable that off-patent drug has been since 2001. Before the sale, Questar had, which is the company that owned it before, had disclosed that its marketing practice were under investigation by the United States attorneys. I don't know about you, and I'm sorry if I offend anybody, but I don't trust anything by the government. I don't care what side of the aisle you're on. And this company, Mallinckrodt, that owns it now, has not entirely escaped the attention of the Senate committee. They have been restricting the sale of it, but it continues to happen. So all I'm giving you is the kind of information that makes you wonder about the efficacy when people are giving up meals to pay for health care. And there is a drug that's gone up from $40 to, what did I tell you it was, $300 and some thousand dollars, $40 a vial to $38,000 a vial today. And Medicare spends an average of $162,371 on a patient on this medication a year, and you are paying for it. I'm not saying there can't be a cure for some of these conditions, but especially with acute multiple sclerosis and rheumatic disorders. But I also see it being a scam by the drug company to implement. We can go back to the EpiPen that was such an issue here a few months ago, and the new generic EpiPen is going to be coming out at the end of this year, so it should be out either this week or next week at half the price, and they're still making a ton of money off of it. So again, I don't know what our option is other than to talk to your legislature and see if they can continue to put pressure on these companies. It did work with epinephrine. It did work with EpiPen. It's still going to be overpriced, but it's going to be half the price it was before. That still leaves plenty of money for Mylan Pharmaceuticals and plenty of money for the pharmacy benefit managers. Still a costly thing for you or your children that have an allergy to any kind of thing and have to use EpiPen, and sometimes you have to have two of them, one in school and one at home, and sometimes it takes more than one to reverse the action of that allergy medication or allergy food, the allergic food that you took. So we're trying to do whatever we can to put a lid on these prices. And I know when you're in the pharmacy and your copay has gone up, or you happen to be in the donut hole, as many people will be until January, which is just a few days away, and then you have a deductible to meet all over again, you wonder where health care is going. Believe me, I own 2 pharmacies. I struggle every day looking at what our profit is from the medications that we dispensed on a daily basis, and out of probably 50% of the drugs that we dispense, we make less than 10% gross profit, not net profit, gross profit from the time that we sell them. We're going to take a break. When we come back, we're going to talk about statin drugs, and that's no surprise, but it's tied to better surgery outcomes.
Hi, I'm Bill Kearney from Northlake Medical Pharmacy. Recently, I visited Mrs. Goodwin's 3rd grade class at Lakeport Elementary School to answer some of the students' questions about their health. Here's what they had to ask.
Why do I have to drink medicines that taste bad?
First, the medicine that makes you better tastes bad originally, and the maker of the drug tries to make it taste better, but not perfect. Second, if all medicine tastes good, there would be the risk of you wanting to take more of it than you need, an overdose, and make you sicker. Northlake Medical Pharmacy, a good neighbor pharmacy, is offering a Healthy Kids free vitamin program to the kids of Lake County. Any child aged 2 to 12 can receive a free 30-day supply of children's chewable multivitamins every month for a year. Simply sign up your children at either of our 2 locations at 347 Lakeport Boulevard in front of the Bruno's Shop Smart. Call 263-1328 or at 5136 Hill Road East across from Sutter Lakeside Hospital. Call 263-6192. The Healthy Kids free vitamin program at Northlake Medical Pharmacies.
They're good for us.
Who do I wrestle for? I wrestle on my high school team for Jason Garcia, my fiercest competitor during practice and my biggest fan during meets. I wrestle for my parents who practice what they preach, the importance of hard work, commitment, and dedication. I wrestle for the chance to put our little high school right here in California on the map.
Wearing the uniform of your high school comes with a big responsibility. Younger kids look up to you. Your teammates count on you. And the reputation of your high school depends on you. Do you have what it takes to participate in a high school sport?
And I wrestle for the glory that is mine when I do my best. That's who I wrestle for.
This message presented by the California Interscholastic Federation and the California State Athletic Directors Association.
We're asking folks about marriage.
Marriage makes me think of sports. You know, teamwork, dedication.
Okay, let's see what people say.
Let's say your marriage is a sport. What sport would it be?
Basketball.
Surfing.
They have to be a team sport.
A lot of back and forth.
A lot of people watching.
So how many people are influenced by your marriage?
Hundreds.
You really think about the ripple effect.
It's like a wave.
Want to improve your marriage? For ideas, go to foryourmarriage.org. A message from the Catholic Church.
A single ember that escapes from a wildfire can travel over a mile, carrying a world of trouble. It can land, ignite, and destroy your home and community. You can't control where that ember will land, only what happens before it does. With simple things like clearing areas around buildings, knowing community safe zones, and being prepared for wildfires, you could keep this from turning into this. Your home is better protected from wildfire when your whole community is prepared. Visit fireadapted.org for more tips on how to get started adapting your home and community to wildfires. A public service message brought to you by the U.S. Forest Service and the Ad Council.
All right, we're back.
We are back, and we were going to talk about statins. Statins, as most of you know, are drugs that are used for high cholesterol. Torvastatin, which is Lipitor, Simvastatin, which is Mevacor, Lovastatin, all kinds of statin medications, Pravastatin. A study came out, this was in the New York Times yesterday, that taking statins may make surgery safer. And one of the reasons I don't get into a lot of different studies is because the size of them are so small. But this was 96,486 surgeries in the VA. It included a wide range of operations, though not heart surgery. The average age of the patients was 65. Almost all of them were men. About half were taking statins the day before and the day after their operations. Those on statins had an 18% lower risk of death within 30 days and an 18% lower risk of complications than those who are not taking the medicine. And this was reported in the Journal of the American Medical Association, Internal Medicine. These statins improve blood vessel functions and lower inflammation, which may account for a lot of the benefits. They accounted for dozens of factors that led people to take statins in the first place in order to reduce the likelihood of a healthy user bias, that is, possibility that people who took statins were simply healthier to begin with and therefore more likely to thrive. The effects of the healthy user cannot be eliminated in these studies, but the lead author from the University of California in San Francisco said, the effect was modest. It was still a patient over 45 with some risk factors, borderline cholesterol level, hypertension, and might consider discussing statins with their surgeon before they take surgery. Now, we're not talking about maintenance. We were talking about just taking it before and taking it after surgery. Again, a new study. I'd never heard of this before. I've heard of when you had a cardiovascular event and you have a bypass or you have angioplasty or something, by putting you on 80 milligrams of atorvastatin, which is a very high dosage, but that became the standard of practice about a year ago. But this is completely a different thing that we're talking about, and maybe something that will become a standard of practice later. You've heard us talk about opiate addiction and the death toll of people taking oxycodone and hydrocodone. Excuse me. There's a headline that opiates contributed to a rising death toll of 28,647 in 2014. There were 47,000 deaths from accidental drug overdoses, and opiates were indicated in 28,647 of those. From 2014 to 2015, this increased by almost 16%, and 72% of the deaths were from synthetic opiates, mostly fentanyl and heroin. It's so rare to see a cause of death increased in the United States because we do such a good job of treating the reasons that people have them. But since the year 2000, more than 300,000 people have died of opiates and have yet to decrease any place. Morphine and codeine are the natural opiates that are found in opium poppy. Synthetic opiates like oxycodone, hydrocodone, and hydromorphone are derived from them. Many are familiar names under brand names. Oxycodone is sold as Percocet, and that's with Tylenol and Percodan for aspirin. Hydrocodone as Norco and Vicodin. The rate of drug overdose deaths increased in the United States and in Washington, D.C., and it remained stable in 19 states. In 2 states, Florida and South Carolina, rates decreased for a time, then increased again. So from 2014 to 15, deaths involving synthetic opiates from other than methadone and heroin were highest in the Northeast and lowest in the West. And also death rates among men using these drugs more than among women. Deaths of women were 15 to 24, increased by 116%, the highest of any sex or age group. So this is leading up to an article that I wasn't going to talk about today, and I just saw in the Santa Rosa Press-Democrat today. And the headlines in a Nation World section was OxyContin makers go global as U.S. use falls. OxyContin is a dying business in America, with the nation in grip of an opioid epidemic that has claimed more than 300,000 lives. It's turning away from painkillers. Top health officials are discouraging primary care doctors from prescribing them for chronic pain, saying there's no proof that they work long-term and substantial evidence that they put patients at risk. Now, I don't know what I would do if I was an owner of these companies, because they're losing billions and billions of dollars, because prescriptions for OxyContin have fallen nearly 40% since 2010, meaning billions of dollars in lost revenue for the manufacturers, which is Purdue Pharmaceutical. Since the company's owners, which is the Sackler family, adopted a new strategy, put the painkiller that set off the crisis into medicine cabinets around the world, now they are moving rapidly to Latin America, Asia, Middle East, Africa, and other regions for pushing for the broad use of painkillers in places ill-prepared to deal with the abuse. Now, I don't know if you're aware, but it took the United States a long time to put the skids on opiate use as far as legal prescription drugs go. One of the things that spurred the increase in opiate use was putting pain relief on the vital signs that hospitals would take when they made their rounds, and as well as taking high blood pressure results, pulmonary results, whether your breathing rate was efficient or not, your pulse rate, blood pressure, and such, whether you had a fever or not. Now they were ordered by law to check your pain relief. And if you've been in a hospital or in a clinic and you've filled out an application to do therapy or whatever it is, there are smiley faces. And up go 1 to 10 deciding what your pain level is, your pain threshold is. And I had a person tell me that you always go to 10. You always tell them 10 if you want opiates. If 9, you'll probably get hydrocodone. 10, you'll get oxycodone. And so hospitals, in fear of credentialing being a failure, started treating people that said they had a high pain threshold or low pain threshold, and they needed more opiates in order to get them under pain relief. Not only were hospitals and clinics involved, but doctors' offices were involved, and they did not want to be approached by the Drug Enforcement Administration of not relieving people's pain. Well, instead, what happened is we overreacted because of legislative concerns and credentialing concerns, and anytime anybody said they had a 8 or a 9 or a 10, we gave them hydrocodone or oxycodone instead of Tylenol with codeine, or one of the other drugs that we used to give for an anti-inflammatory to help reduce pain. Not only did we do that, we did a cocktail that had muscle relaxants in it, as well as anxiety medication, as well as the opiates. So we had a double or triple addiction going on. And it became the way of life. For many doctors capitalized on this. Most did not, but their effort was sincere in trying to control a person's pain. One thing we know in the pharmacy business and in the field of medicine is that everybody has a different response to pain relief. And what may calm my pain down or may put it on the low scale of needing to have opiates, somebody else could very much in truth have a pain level of something that would require nothing for me, that would require a high opiate dose for them. And it got to the point where we didn't want to hurt. You know, I've had many surgeries, as you know, and almost every time I came out of surgery, OxyContin or oxycodone was prescribed for me for post-surgery, after surgery, for a month or so until I saw a surgeon. And sometimes it was continued on beyond that time. Me being well aware of what those drugs do, I tried to go without, and still continue to this day, go without opiates for my pain, because I would rather tolerate than be addicted. The purpose of oxycodone and OxyContin and morphine and MS-Contin were to have a continual flow of analgesic, meaning something that would keep the pain level below a certain level so you wouldn't have these peaks and valleys of it works until it starts to wear off in 4 to 6 hours. Then I wait until the 6 hours, and then I take another one, and then I peak out to where I'm up above the pain threshold again, and I'm doing fine, and then it starts to wear off. And so we made them long-acting. So, number one, you could take the medication. It would relieve the pain. And number two, you could function as a person that was on this medication and not go through the trauma of it wearing off and then having to go back up again and then it wearing off and going back again. Well, when we started doing research, we found out that over a period of time, and this has been debatable, that after about 3 months, the oxycodones and OxyContin and morphine controlled release did not work any longer. But we just took it because we didn't want to hurt. Not that we were hurting, but we thought that if we didn't take it, we would be hurting. And so we developed this large body of patients that depended on this all the time. And we continued for chronic pain is different than acute pain. Acute pain is something that comes when you break your arm or break your leg or whatever, and then once it's fixed, it goes away. And that's why during the healing process, the physicians would give that to you. But more and more people, when they came in, would circle that number 10 and say they needed it more, and so we continued to give people that. Now, if terminal is the reason that you're giving it and people are dying, that's practically justified. But when you take that element out, it's just like marijuana, medical marijuana. It's a real thing in California now, as recreational marijuana is. But the amount of people that bought medical marijuana that actually needed it for medicine was quite small. The amount of people that were taking opiates that really needed it is quite small. We created a population of patients that we developed the need for that by telling them we would give it to them. And now, as you see, when you try to get a prescription like that, when you go to a physician, many physicians are backing off, and even Partnership Health, which is the Medicaid of California in this county, the maximum you can get is 30 at a time, and the directions are one every day. The purpose of them determining it's unless we get a temporary authorization request is that get you used to the fact that one a day is going to solve your problem once you get used to not taking it multiple times a day. The Partnership Health has been very cooperative in granting temporary requests, authorization requests for that medication, which we call TARS, but you have to go through the process of the 30 pills first. Now when makers go global, as the use in the United States falls down to nothing, you can look in the Press Democrat today, and there is a whole half a page devoted to the billions of dollars that OxyContin has generated, nearly $35 billion in revenue over the last 2 decades. And family members don't want to be contacted on this story. They are wooing doctors in other parts of the world to get them to attend seminars that will tell them how much that this drug is going to help the individuals, even if they're becoming addicted. One key opinion leader who attended one of the seminars was from Mexico City, a pain doctor who holds the position of Mexico's National Cancer Institute. He now speaks at the seminars in Mexico, and his aim was to help demystify the use of opiates in chronic pain, and said he was not paid for his appearances. We need to work to eradicate so people can, or educate so people can use analgesics more. He said that he was not concerned that Mexico would have a large-scale abuse and addiction. If we educate our doctors and our patients, but there's always happens to be, as ethical as you think your physicians might be, or in other countries we think they might be, Purdue charges hundreds of dollars a bottle for a month's supply of OxyContin in the U.S., which provides similar pain relief as morphine, can cost as little as 15 cents a day. So chronic pain patients who fill prescriptions on a monthly basis have been the driver of billion-dollar sales for Purdue and for around 2 decades. So this is not going to go away. And I can tell you right now, if you know, as an opiate user, you can go to Mexico and get opiates and continue your addiction, you're going to do it. And I have said a long time ago, I believed in legal addiction in many cases. If the fact that you were taking heroin, the fact that you were taking oxycodone, the fact that you were taking MS Contin allowed you to be a truck driver, allowed you to be on the road and not be compromised by the drug, then it was a good thing. But we let it get completely out of hand. And there was a venue for physicians to use to fill out a document that said, this patient is an addict, and I have made them an addict, but he's serving a useful part of society, and I'm willing to do this. And you were able to do that in the state of California. And in a situation like that where the pain, it doesn't make any difference to me whether they say that the opiate wasn't useful or not. If you think it was, and you're bedridden because you can't get the medication, I think that you deserve the right to get it. But to go into other countries and promote the use of that so more and more people get addicted, and these are poor countries. It's not going to sell for the same price it's sold for in the United States. It's going to be a lot less. And you have no way of changing this, no way of turning it around, no way of treating the addicts, no way of cutting it off. The Slacker family, who owns Purdue Frederick, is not going to care about whether or not you're addicted or not. All they're caring about is the amount of sales that they can derive out of taking this product internationally. You know, right now you can go to Mexico and get drugs, and I was in Tahiti a couple of years ago, and I had a severe toothache, and I had a prescription for Vicodin, and I got the infection. It was an abscess tooth. I got the infection on the plane on the way over there. And I walked into a pharmacy in Papeete and told them that, or maybe it was Rarotonga. It was one of the islands that were out in the middle of the Pacific. I think it was Rarotonga because the pharmacist was from New Zealand. And I told them what I wanted, what I needed to get a refill on, and the pharmacist filled the prescription. And I says, how can you do that without a physician? She said, well, we're trained. We didn't go to school to be pharmacists. We're trained to be a pharmacy technician, and we can dispense medications. Now, if you wanted a cardiac drug, like digoxin or Lanoxin or something like that, we couldn't give it to you. But for a pain relief drug, we could. There's a lot to be said about that. In one way is pain and suffering is something that is given the right to pharmacists, even in the United States. If a patient is out of their pain medication and they're a patient of yours that you know has been compliant and is taking the medication correctly and part of your daily records, and you know this patient is loyal about taking the medication, and it happens to be a weekend and you're out, and there are several drugs in several categories, and if you don't know what those are, check with your pharmacy. But a beta blocker is one of those, altenolol, Inderol, many of those drugs that are in that category that control AFib and control high blood pressure, control anxiety. Getting off those is just as dangerous as getting off a narcotic. So over a 72-hour period, you could go through a withdrawal process that would be severe to you. Same way with antidepressants, what we call SSRIs, serotonin reuptake inhibitors. You go without those for 72 hours, and you go through a withdrawal process that is drastic. You may make it through that okay, but you'll wonder what happened to you. And you can probably survive it, but you throw a couple of other things in there with it, like Xanax or Ativan or one of those drugs, and addiction to that becomes probable too. I talked to a girl 14 years old this weekend that her friends were taking, in high school, were taking Xanax and alcohol. And I explained to this girl, I said, who said she wasn't participating in this, I said, if you are, you're going to have a double problem here. You're going to be addicted to Xanax and be as addicted to alcohol. And one of these days, and you can get by with taking both of those drugs at one time, and I wasn't aware that this was a new thing for adolescents, but it is. I said, and this happens to actors and people in the theater all the time and in the arts. They take the Xanax and they take the alcohol to come down from amphetamine use or cocaine use, and they're okay for maybe 8 or 9, 10 times, and then all of a sudden they both hit the central nervous system at the same time, and you die. Now that's the most drastic thing that can happen, but that can happen, and it will happen at some point. So again, if you know anybody that's involved in this, and the person that spoke to me about this was the most unlikely person in my life to tell me something like this, and you would be amazed at 14 years old what's going on in the school system as far as taking drugs and alcohol. So we've covered a lot of things today that were kind of pieces that needed to be caught up on. I'm sorry if my presentation hasn't been one of the best, but I want to remind you that there are still flu shots, and we still need to get the last few flu shots given to people who haven't gotten it yet. This condition that I'm aware of, excuse me, that took over my life on Christmas Eve, is going around also. There isn't any cure for that, but taking a thing that has called mucus relief that helps bring the congestion down, and essential oils like eucalyptus oil to smell, to open up your cavities, using saline water or ocean spray, and you can use that to excess where you can't use Afrin or oxymetazoline to excess, or you'll end up having a more difficult time breathing. But you need to take care of yourself, and as Paul just mentioned, a 2-year-old went in with double pneumonia, so that's what can happen. We'd like to remind you we're North Lake Medical Pharmacies with 2 locations for you at 5136 Hill Road East across from Sutter Lakeside Hospital. Call us there at 263-6192, and outside the Bruno, Shop Smart at 347 Lakeport Boulevard, 263-1328. Thank you, Paul.
Thanks, Bill. We'll see everybody back here again in the new year, next Wednesday, here for Health Talk, right here on AM 1270 and 96.5 FM KXVX Lakeport.